our next presenter was really, let's think of this as a case study of why culture change can be so hard. Mike Conroy is the Chief Medical Officer for Sutter Health Medical Group in Sacramento, where I live. And Mike's going to talk about some of the hard discussions he has had in his institution working to change the culture at Sutter Health. So Mike, take it away.
Welcome everybody to the call today. I think Susan did a great job of talking about why this work is important to patients, and Tom posed a lot of the both philosophical and practical reasons why this is important and also why it's a challenge. So I wanted to talk about our story in Sutter Health. If we could have the first slide. The first question is, why would we do this? One of our physicians brought the concept to us a number of years ago, and as we talked about it, we realized we had not solved for the typical communication, navigation through our network, and patient empowerment issues that plague all big medical groups and most organizations, as a matter of fact. Secondly, we thought that providing direct access to the thinking about what did the clinicians do when they prepared a plan for a patient or before they talked with a family, that providing that kind of insight would help the patient empowerment that we were searching for, so people could take more sort of ownership of their health and move themselves to a certain degree through their lives. And we thought that would also increase the trust and collaboration it would build between patients and not just those writing the notes, but the whole health system, really. And
Mike, I hate to interrupt you, but is there a way to get your audio a little better? There's some background noise. It's okay if you can't, but it's a little distracting.
You know what? I apologize. I'm dialed in through the computer. It's the only link I have.
Okay, that's fine then. We can understand.
So I'm sorry about that. The third thing we realized is that the under 35 crowd, sort of the millennial crowd, was increasingly expecting transparency, and we were seeing this pop up in a number of ways. People asking for more reports, more copies of their notes when they were still on paper, and then when we had to print them out from the EHR and so forth. And we really thought that OpenNotes gave us an opportunity to get ahead of this curve, and that instead of sort of waiting for outside forces to sort of make us do something around transparency, that we would take advantage of this and get ahead of the curve, so to speak, and learn about how we would best use this system. So next slide. So how did we do this? I think people recognize this clinician. Initially, we piloted with about 45 early adopters around our system. They really had a good experience. They didn't get an increased number of patient communications. There weren't people asking for corrections. They felt better connected to their patients. So then we took this idea to a larger number of people and talked about it a little bit more. We ran into three particular things, and this ties right into what Tom was talking about. The first, I'm sorry, go back a step there, thank you. The first is that we were going to confuse patients. We were going to trouble them because we were revealing information that maybe they didn't know or understand, or they would read things they wouldn't like, or they disagreed with, and it would cause emotional distress and perhaps worse decision-making in our patients. That was a big concern. The second one is this will increase my work. We hear this about almost anything we do related to communication with patients. We'll get more phone calls, more online messages, we'll have requests for corrections, there'll be people rushing in for appointments and so forth. And then the third one Tom already mentioned is the issue of the notes are mine. They don't belong to patients. There's something I create, they're for me to communicate with my colleagues. And this is actually, I can't undersell, this is quite an issue for some clinicians. It's quite an emotional issue. All right, so the next slide. So after we piloted with this second group, the people we call the curmudgeons, we really got the same feedback. They came back and said, actually, this wasn't so bad. The bad things that they were concerned about really didn't happen. And so we decided to go live with the entire group. Our experience with the way patients responded were these. You can see them on the slide. And they're really three separate categories. The first one we did not expect at all. The number of people who wrote back expressing sincere, deep appreciation for the thought that the clinicians are putting into their care. That was a surprise to a lot of people. The second one was a category I'm just calling simple corrections where people would say left instead of right, or they document, I'm sorry, left instead of right in the note. This is pretty important, I think, to get these things right. And then the third category is we did get a few people that wanted to improve their history and say, you know, I left this out, or I'd like to add this to my note. These weren't corrective, they were more additive. All right, next slide. And then I'll let people read this for a second, but this gives you a sense of how we had many people express this kind of deep appreciation and gratitude for the effort that their clinicians put into caring for them that they hadn't really appreciated in the same way before. And these were, by the way, both of these were patient comments that we got back on surveys. These weren't things that were emailed back to the patient or, you know, left in a phone message. These came back to our patient comments through our patient experience survey. All right, next slide. So where are we today after all of this? We followed data for 6 months to try to address the issue of this will increase my work. And we actually did find that neither the online messages into our system nor the phone calls increased after we went live. We tracked this for about 6 months. I looked at it again a year later. It was a little harder to trend because we'd added a lot of clinicians at that point, but we did not see a change in the overall work coming into our clinicians. Secondly, the feedback was there really not much happened. In fact, when I went back 6 months ago or so in preparation for this phone call and asked a few people about their experience, still had a number of clinicians who weren't even aware that we were live with OpenNotes. Now, that has both good and bad, which I'll address in a minute, but the actual impact on the day-to-day practice was essentially none. We sort of taught people if they wanted to hide their notes, they could do so. We have a small number of clinicians who we kind of tease them. They had a pinky pledge going into this, 3 small departments in particular, who all agreed that they were going to just hide all their notes. They just didn't like the whole thing and couldn't really penetrate into their psyche very well. And that group now, over 2 years later, continues to hide many of their notes. But the large majority of our clinicians, and we're just over 1,000 doctors in our group now, none of them hide notes at all. And then the last point you see on the slide here is something that's also a little bit disappointing to me in that we do have regular readership, and we have some of our clinicians where readership of the note is up in the 25% range, which I'm really happy about, but I would really like to see overall readership much higher than this. The other learning was that it's difficult to predict who will have a higher likelihood of readership. When I talked with several of our OB doctors about it, I just assumed it would be women who were pregnant and were sort of anxious about confirmatory information about the baby, and the doctors looked at me and said, "No, you're nuts. You know, no OB patient leaves the doctor's office without asking questions or knowing what's happening." It was all their GYN oncology patients or people worried about abnormal PAPs and that sort of thing that were going back in, and I think the looking into the notes was a desire for more reassurance that, you know, they could see that their final pathology was negative or verifying what results they had. So it's a little hard. It was hard going in. I didn't predict very well who would read. Other thing that was amazing to me is that I also thought that the doctors who had high readerships were more likely to encourage their patients to read their notes, and that is not what we found. We have some doctors who mention it almost every time to their patients who don't have high readership, and we have other doctors who told me they've never mentioned it to a patient a single time who have high readership. So that part's very interesting to me. And so what would I do differently? I don't have a slide for this. What would we do differently going backwards? First of all, I really would have worked harder to get the patient voice very loud and very clear up front of all of this work. We did talk with our patient advisors. We got the sort of thumbs up, this is a great idea, but it would have been much more powerful to sort of film 5 minutes of a patient advisor meeting or get a statement from a number of people, which we did do later as we started to spread across our network, but it would have been very helpful if we had that the very first time through. The second thing was a more robust plan for getting before and after data, particularly things that were meaningful to the clinicians. I talked about the measurement of My Health Online and phone calls, but we didn't really talk to our clinicians first about what they would like to see in terms of measures, both to demonstrate a positive effect and then to verify that they weren't being damaged in some way. And then finally, we didn't design any measures that would indicate whether patient outcomes actually got better as a result of access to this information. And in retrospect, I really wish we would have picked one thing to focus on that we could have educated patients on, driven them into excitement about reading their notes and using the information differently, that we could have measured to demonstrate the benefit. And I know the consortium has done all of these three things. There's research now out there and available, and other organizations are doing all of these. Again, I wish we had done some of this more thoroughly to start with. So our notes are available for everybody from all the ambulatory clinicians. So primary care and specialty. We do not have behavioral health as an integrated part of our network, so I can't respond to that. Our local hospital administrations are actively looking at opening up OpenNotes for hospital notes, but again, we're not doing that at this point in time. And then just two other anecdotes. We're one of several medical groups within the big umbrella of Sutter Health here in Northern California. And at the moment, we are the only medical group that's gone live. We're having the same conversations that you saw on these slides and what Tom talked about earlier to try to overcome some of the concerns at the other medical groups. And I'm pleased to say that 3 of the others are now in the active process of going live. They determined that they want to do so. So I think that's a positive move forward. However, there are still a couple of the groups in our network that are not really at that place, not really ready to move forward. The second thing, just about the experience, as I mentioned, we're one of several groups. We have a group just up to the north of us who is part of our Epic build. And when we went live, they went live too, and they had literally no preparation, no conversations about OpenNotes, what it was, that they would or should go live. It just was a technical thing that happened. And I asked the group president about a week after what happened, and he looked at me and he said, "What's OpenNotes?" And he kind of laughed. And he's an actively practicing clinician, and it turned out that there was literally no demonstrable impact on the day-to-day life of the doctors, even those that had literally no advance warning that this was going to happen. So I think I'll stop there unless there's anything else that people want me to address. We can wait till the Q&A.
Yeah, Mike, thanks so much.